and I'll be helping to just keep us on time here. So it's my pleasure to introduce the moderators for our session, James Rathmell, the chairman of the Department of Anesthesia, Anesthesiology, Perioperative, and Pain Medicine at the Brigham, and Jeanine Wiener-Kronish, the Anesthetist-in-Chief at Mass General Hospital. So I'll turn things over to them for some introductory comments and to introduce our panelists for today.
Thanks, Emmy, and thanks to all of you for coming, and Jeanine, thanks for co-hosting this. We had a lot of fun digging up various people in our departments that are doing really new and innovative things, and want to share that with you. I thought I would start, so the way we're going to do the panel today, we want to keep it very informal. In the beginning, we're going to give you 2 or 3 minutes, maximum of 5 minutes, just to give you a flavor of what each of these individuals is doing. We want to reserve half or more of the time for questions directly from you to us that we will do our best to field for you. So I wanted to start first by just showing you the environment we're in. You know, anesthesiologists are a very, very diverse group of individuals in this day and age. We spend a lot of time in the operating room, but we spend time outside of the operating room caring for patients with acute and chronic pain, as well as patients in the critical care realm. So a lot of different places we are, and I want to show you those environments. This is the total joint room at Mass General, and you can see from the anesthesiologist point of view, there we are at the head of the bed. There's a trainee to the left and one of our attendings to the right. There's a heads-up display he has his finger pointing toward that's recording all of the data in real time. So we have electronic anesthesia records. Then to the right is a data display. The first monitor to the right is things like electrocardiogram and blood pressure. The next one to the right is a compressed spectral array EEG monitor that is a depth of anesthesia monitor. And then below it is the anesthesia machine, which is also filled with data that pertains to the patient, like mechanical ventilation data. So you can see to the left a rack of infusion pumps. We do most of our things through electronic infusion pumps, most of our drug administration, or a lot of it. And then we handle things like fluids and blood administration during the intraoperative period. It's a pretty complex environment that's data rich. That's the point here. Now, what do we do with that data? And I want to show you a couple of other perspectives. This is the next level up. That was a general room where we were doing an awake total joint replacement under spinal anesthesia. Relatively low in complexity when it comes to the anesthesiologist and what we do. This is the other end of the spectrum, which is from the perfusionist standpoint, cardiopulmonary bypass. That's the heart-lung machine. We're kind of looking up toward the surgeons in the middle of the field, and to the right, with their backs turned to us, are the anesthesiologists during cardiopulmonary bypass. So there's a whole new level of physiologic data that we're trying to interpret to the patient's best end. This is the other end of that same room, and it's 2 of our cardiac anesthesiologists, Gabriella and John Fox, here at the head of the best, and they're doing transesophageal echocardiography. So we use real-time imaging to help guide some of our decisions. So imaging comes into it as well as all of this raft of physiologic data. You can see to the right the panel of monitors, in the background those infusion pumps. In this, we have a very complex array of data that we're dealing with. And this is kind of what it looks like. We're doing a scan constantly. The left is the anesthesia record, kind of plotting things. We see the physiologic waveforms. To the right, upper right-hand corner is the compressed spectral array, the BIS monitor, or depth of anesthesia monitor. And down to the right is just a general plain old anesthetic, the minimum monitoring that we would have: electrocardiography, non-invasive blood pressure, heart rate there, temperature, and then some EKG ST segment analysis. Now in the ICU, it's equally complex, and there are all of the same sorts of physiologic monitoring. And then there's a whole new set of data that's available to us, but we don't use all that commonly, and that's the ventilator-associated data that may be able to tell us something about early trends in pulmonary function gone awry that we don't really track in real time. We look at periodically. So there's a whole wealth of data that we're doing these spot interpretations of, but this longitudinal interpretation is left to us to synthesize in our brains. So and then just a little bit about the pain realm, where we use image-guided intervention. That's on the left to do some of our pain treatments. We interpret complex imaging data to make treatment decisions. And then at the bottom, I put in, this is the opioid epidemic and the epidemic of opioid overdoses in the US. We have prescription writing. We have electronic medical records, but we have no idea what's happening out there in the community, what other prescriptions they're getting, what's happening to our patient over time as they take those prescriptions. There's relatively no monitoring to help guide our treatment decisions out there. So we have a lot of data that's not very well synthesized. Now, today we have 4 different speakers who are going to give little snippets into what they're doing, and they're very, very innovative. We have people all the way from the beginning of their careers to very senior faculty that are going to present to you today. And I think most of what we have, there's a little bit in the basic science, but most of what we're going to talk about today is care delivery, both monitoring, but then synthesizing, and maybe even getting to complex interpretation that a human being can't do that guides our decision-making in the operating room, in the ICU, and in the clinic. So with that, I'm going to start our first speaker. It's Chris Connor. Chris is an MD, PhD. He went to Harvard Medical School and then MIT, where he got a PhD in biomedical engineering. I guess you got a master's in Cambridge as well in biomedical engineering. So he is a through and through biomedical engineer who is always thinking innovatively. He's going to share with you some of the clinical applications he sees, as well as what he's doing in the basic science laboratory. And his will be the most precisely engineering type timing of a 3-minute presentation you can ever imagine. All right, Chris, come on up and I'll get you started.
Good. Hi, I'm Chris Connor. So I'm going to talk to you about 3 different topics in artificial intelligence and machine learning in anesthesiology. One of these is already technically achieved, the second one is in progress, and the third one is what we're reaching for in the future. And I'm going to do this in 3 minutes, so we can have 3 topics in 3 minutes, so that's 1 big idea per minute. So if you're not interested in the idea I'm telling you, don't worry about it, because in a minute there's going to be another idea. And I'm essentially going to do this, to stay on time, I'm going to do this like James Brown. I'm going to get up, I'm going to get on the scene, I'm going to hit it and quit. So with that in mind, Jim, can you, begin. Yes. So imagine that you have a number of hospitals spread out geographically, and you have to send anesthesiologists to cover them. And anesthesiologists are expensive, so you want to do that as efficiently as possible. You can have an app on their phone which sends a message to a server when they arrive or leave from a hospital. So this allows you to track your anesthesiologist in real time. Here's me moving around geographically, so you can see what I'm doing at any particular time, and you have this data for any of your anesthesiologists, so you can mine out of that the most efficient way to structure your practice. And you might think that anesthesiologists would hate that, but you would be completely wrong, because the app is set up in such a way that its operation is transparent. So the location data for all the anesthesiologists is shared through the app with all the other anesthesiologists. So anyone can see at any particular time where their colleagues are. And this is important, because if you have a problem, you need help, and the app allows you to page them or send an SMS to them immediately. So this was already covered by Harvard Business Review. Now, imagine you have to intubate somebody. This is a critical procedure that anesthesiologists perform all the time in order to give you anesthetic gas or control your breathing for surgery. Normally, this process goes very smoothly. Sometimes some patients are aberrant anatomically, and it's difficult to get the tube in. This is very dangerous for them. They can die from lack of oxygen. We think we can sometimes recognize these patients from their facial appearance before the surgery. We have a machine learning project to do facial recognition. Here's me. Here are 3 pictures of me like my police mugshot. And from that, the system can reconstruct a 3-dimensional model of my head and neck. And it can apply a mesh to that and measure various proportions. And from that, it can make predictions on whether I'm likely to be difficult to intubate, like that guy would be, or easy to intubate, like that guy would be. And there really isn't any anesthesiologist who would disagree with those assessments, and we've had 2 very successful publications out of this. This is also patented through partners, so we would love your investment to bring this to commercialization. Now, finally, imagine you have to determine whether something is conscious or not. You could do an EEG. That's a little like picking up electromagnetic interference from a computer and trying to work out how it's working. Not terribly precise. You could do fMRI, which is where you look to see which parts of the brain are active. That's really like looking at a computer motherboard with an infrared camera and seeing which parts get hot when it does something. So here's a cat video. That's the part of the motherboard that likes cat videos, which we call the video card. What you'd really want is a simple computer where you could see the action of every single circuit in it. The biological equivalent of that is this, which we have in my lab. This is a very simple nematode worm, and all of its neurons are labeled with a fluorescent protein. So as it thinks and goes about its worm life, you can see its brain work. We actually do it in 3D, not flat. The red dots here are the nuclei of each of the neurons, and it flashes in green as the worm thinks. And we are using artificial and machine intelligence to try to figure out how the worm becomes unconscious as we expose it to anesthetic gas, and how it wakes up again. Thank you. Thank you.
Speaker is William Driscoll, who's in charge of everything in my department, but his title is the Director of Clinical Bioengineering and IT. He also runs the IT for the Brigham as well.
Thank you, Jeanine. As Jeanine mentioned, I'm the Director of Perioperative Clinical Engineering and IT Systems. My team is essentially responsible to support all these clinician innovators in the department at Mass General and recently at Brigham and Women's. We, as a non-clinician, I wanted to just offer some insights onto how AI in anesthesiology is evolving and how we go about thinking about how to support the clinicians in those endeavors. So I want to start off with about 6 different main points. The first one is, how do you get a project from the lab to actually into clinical operations? And from the slides that Jim showed, it's a complex environment, so there's a lot of factors that go into it. There's a lot of connections, a lot of data points. So thinking about the type of people and the insights needed to get the data to achieve your projects. So beyond the clinician investigator who is looking to solve a problem, what's the team that's needed? And we're in the fortunate position to have a support team through the support of our chairs to help fund our positions, to help build out these IT networks, make those data connections, produce those data warehouses to get the data and achieve those algorithms and the projects that are in place. Oh, should I? That better? No, I don't have a slide. I was just moving that one along.
Sorry.
It's okay. And so as any of these projects are starting off, we want to think about, well, what is the data that you need? And if it's a clinical project in the operating room and you're pulling the data from those biomedical devices, if you're tapping into the electronic medical record, if you're choosing data from other sources, audio and visual routing systems, and additional systems that might be in place, and synthesizing those data. You have to really think strategically about how to pull that data together, how to set up the system to bind the data so that you know if it's coming from multiple sources, that all of that data is linked to a particular patient encounter, to either achieve in one patient in one setting, whether it's a closed loop anesthetic type project, or if you're pulling lots of data from lots of patients and trying to put together a big data mart and do predictive analytics and outcomes research. If you're doing a real-time or retrospective analysis, you either need to decide, are you going to do your computing at the point of care, or if you're going to do all your computing on a server in a data center. These are important considerations, especially if you're thinking about the real-time monitoring that's going into place. We don't want to have any adverse effects on the primary alarm systems. We don't want to have the computing that's going on cause any problems. So we want to be considerate about what type of computing, how do you move that data, how do you analyze that data, and then produce actionable alerts from that data. With respect to the environment, you saw how busy it was. If you're putting together a dashboard or an alert system, where does it fit into that whole cockpit of care? If it's an additional monitor, what's the cognitive load on the clinician? How do you get the right information to the right clinicians? So these are just a bunch of things that I wanted to plant some seeds for everybody to think about as you're starting to do an AI type project, and having the right team to put it all together is very important. Thank you.
Teamwork here. So the next speaker is Dusan, who is very special in that he's an immunologist and was a researcher for years prior to seeing the light and becoming a clinician as well. He's our intensive care faculty at MGH.
Thank you, Jeanine, for introduction. I would like to spend next few minutes just illustrating how tools of AI can help us understand inflammation, can help us study inflammation in ARDS, or acute respiratory distress syndrome. ARDS is a syndrome in which excessive inflammation, excessive pulmonary inflammation leads to diffuse alveolar damage, bilateral pulmonary edemas, and we as intensivists typically provide supportive care. The fact is that ARDS currently has no targeted therapy and is still associated with fairly high mortality. Although we do believe that inflammation is somewhere at the center of this syndrome, the inflammatory mechanisms in ARDS are still poorly understood. How can we study inflammation? If you take a microscope and look at the alveoli with high magnification, you can really appreciate that immune cells constitute very large population. They are very abundant around the alveoli, also inside the alveoli. These are green cells on the illustration. There are really two approaches how to study immune system. One is reductionist approach, where an investigator chooses to study neutrophils, T cells, or some receptor, and really compares the expression of the marker between normal tissue and pathologic tissue or inflamed tissue. However, we know that these approaches have so far not led to any effective treatments in ARDS. The other, or in contrast, the other approach is a systems immunology approach that we do believe should be used in studies of critically ill patients. And this approach can characterize whole immune system in the lung or in other sites as a whole, and potentially identify therapeutic targets. Here I'm just going to use examples of my own work, utilizing mass cytometry, which is a highly sensitive method to characterize all components of the immune system at the same point. Mass cytometry generates large amount of high-dimensional data, and in fact, these data are almost impossible or impractical to analyze with typical tools or with traditional tools. Therefore, many AI tools have recently been developed to analyze this data utilizing unsupervised or supervised learning approaches. When we use dimensionality reduction, we are actually able to visualize all components of the immune system in normal lung, in injured lung, in just 2 dimensions. This is in contrast to several hundreds of dimensions that you obtain as a results in your raw data. Utilizing hierarchical clustering, we are able to identify clusters or subsets of immune cell populations with even greater precision. And when this is followed by statistical testing, we are really able to compare abundance of cells in normal tissues versus pathologic tissues or inflamed tissues, or compare their phenotype. Here I am, for example, illustrating that in a certain experimental model of lung injury, we see increased in T cells and decreased in macrophages, which is really in contrast to usual belief that neutrophils are a key population in acute lung injury. In conclusion, I would like to say that AI can certainly identify new inflammatory mechanisms in ARDS, can lead to new drug development, and can guide patient selection for future clinical trials. Thank you.
All right, next up is Jim Phillip. Let me get your slides up. Dr. Phillip is a practicing anesthesiologist and a professor of anesthesia at Harvard Medical School. And he's done a lot with classical pharmacokinetic modeling of inhaled agents over the course of his career, and he's going to share some of his thoughts about where we might go in integrating this complex physiologic data. Jim?
Thank you. I have a disclosure to make at the bottom that minor conflicts of interest that have no real relevance here. First steps to develop AI in monitoring. And I want to focus on monitoring because that's a piece of importance for all of us. Good equipment collecting lots of data in all domains and waveforms when possible, frequent, otherwise 2 seconds, 20 seconds, or 1 minute. Currently, we typically get data collected much less frequently than that. Our current clinical variables of blood pressure and heart rate and the simple standard things are okay, but we need many more variables, and we need a current deeper measures of things such as variability and looking at trends, both coarse changes and fine changes. And then we also want to be looking for immunologic and hormonal measurements of the patient's state during anesthesia. We're nowhere near that at the moment. We want to look at something that has been missing for all along, which is pharmacologic variables. Each drug has an effect, a primary effect and secondary effects. And then on top of that, we don't have recorded the exact time, the flow profile of those drugs, the kinetics of the drugs, and the dynamics of drugs collected or understood by an artificial intelligence system so that it can figure out, analyze, and help us in our care. With our physical variables, exact ventilation pattern and timing of ventilation. The proceduralist, the surgeon usually, but these days almost anyone can be a proceduralist, and the interventions that they produce for the patient and make major changes in this patient's life under anesthesia or even in the ICU. And finally, thoughtful integration of this data is desperately necessary in all of what we're doing. We don't have that. You saw earlier slides of all the various monitors that we're surrounded by in the operating room. Those need to come together somehow. And finally, the data display is displaying it as well as we possibly can. And then we want to allow clinicians to use this data in their clinical care moment by moment and observe good outcomes and a few bad outcomes and collect that data as tightly as I said at the beginning. 1 minute or waveforms for continuous with 250 samples per second with some of our variables. And then collect the full temporal profile for analysis by whatever artificial intelligence engine any of you are going to apply to this data set in the future. In the distant past, we created a GE central display anesthesia delivery system. Its goal was to group variables into physiological systems and display them in groups and monitor and alert on their changes. The clinician would always be aware of the patient's current state. We defined system neighborhoods, and this was implemented in the later to become GE Corporation Central Display Anesthesia Machine, OMITA in that era, where we had anesthetization, ventilation, and oxygenation of the patient. We had alert zones. Here we see the bars over here are the alarms, the dotted lines are the alert zones, and the little footballs are where we are at this moment. We would not wait for alarms to happen. We would like to be alerted. Blood pressure is rising. That's what we want to know. It's falling. This is changing, that is changing. And each of those became an alert, and we would press a button, and it would say, okay, I will move the alert zones to follow those new variables. And it was even shown in a polygon, which never became tremendously successful, but that idea has been done by Dwayne Westenskow and other groups around the world, things of that sort. It wasn't necessary in the one study that we did. It didn't help. Having the graphic trends were really good enough. And graphic trends evolved after that with multiple variables available to see the entire data set, and what we need is something like this, but many, many more. So the next step's now in progress. Data and more data. We want more variables, better time resolution, and the ability to add more monitored variables as the system evolves. If you're building a system to collect this and do something great with it, make sure that when we have more information, or we believe there is more information, we can monitor those variables and actually add those variables to the data set going forward from that time on, not allowing us to be constrained to what we were doing at the beginning. And finally, have a good data set of all the care parameters, all the measurements, and all of the outcomes, both early and late. And then we use this data as an input to the artificial intelligence machine. Whatever artificial intelligence engine learning techniques we are using, that will be able to analyze this. But if we start out with data which isn't good enough, the artificial intelligence will not become intelligence. The word won't apply. So the final result, When we've got good data and good clinicians looking at it, and they're likely to have better outcomes than they achieved before, we'll have machine learning. The specific variables and changes that most influence the outcome will be part of the AI algorithms and will be part of what clinicians understand about their patients. They will learn from the artificial intelligence analysis, and they will likely learn very well. Clinicians will be constantly assisted by an artificial intelligence monitoring assistant. Thank you.
Okay, last but not least is a superstar rising in anesthesia. Kian is still training in critical care, but he started this research when he was a resident, and he's been continuing it since then. So please welcome Kian. He's going to present one of the projects he's been doing.
There we go. I'll be talking to you about a project that's actually a hospital-wide capacity challenge where we've brought machine learning to bear. And it actually falls right in line with a realm that anesthesiologists have been comfortable with for a long time, which is how do we smartly use our capacity? Particularly, we focus on how do we assign and efficiently use ORs. But really, this project was an extension of that through the whole hospital, and we're talking about all of the surgical beds in the hospital and how we use them. So I was the clinical lead on this project where we use machine learning to predict 24 hours in advance which surgical patients will be clinically ready to leave the hospital. It comes out of a collaboration between MIT Sloan and MGH, the PIs of which are Peter Dunn at MGH and Retzef Levy at MIT. And this group has worked on various capacity challenges throughout the hospital for the last 10 years plus. So the core problem here is that, so this is kind of a classic chart in operations management, that above 80% utilization of any given resource, there's an exponential rise in upstream waiting times. So at a place like MGH, where we sit at about 90 to 95% bed occupancy on average, we're in the fat part of this curve. So you have patients waiting in the emergency department for potentially even days to get a bed on the floor. You have patients from the post-anesthesia care unit waiting to get inpatient surgical floor beds. That means you can't get patients out of the operating room, which means you can't get patients into the operating room. So it's really a patient safety problem. It's such a widespread problem amongst hospitals that the state of Massachusetts now requires that hospitals in our state report when they hit critical capacity thresholds. So our aim was to build a machine learning model that accurately predicts a patient's clinical readiness for discharge within 24 hours. And we did that based on a clinical framework where we collected data around milestones that mark a patient's progress towards discharge, as well as barriers that may prevent a discharge. There's really two functions of the tool. One is a real-time function enabling clinicians to have a transparent, shareable, objective list of who should be targeted for discharge that day, and helping them align their practices towards actually successfully getting those patients out of the hospital. The longitudinal function, which is what we focused on mostly in our pilot so far, is really systematically identifying those cases in which a patient's clinically ready to leave, but they don't actually leave the hospital that day. And it opens up a whole new data set where we can study why are these patients not leaving in a timely manner, and how we can design process improvement strategies to address those challenges and hopefully reduce unnecessary extension and length of stay. So the core of our model design was really this framework of collecting data around clinical milestones marking progression of the patient and then discharge barriers. And so we collect data on patient vital signs, flow sheet information like their fluids, ins and outs, the last time they had a bowel movement, when they had an emesis event, what's their neurocognitive function, so on and so forth. We collect everything on their medication administration, the route it was administered, the type of drug, et cetera, et cetera. We collect a lot of lab results. We know whether there's a pending imaging study yet to be done. We know which tubes, lines, and drains are in situ in the patient, when they were placed, when they were removed, and how long since they've been removed. We know what diet they eat. We do free text analytics on case management and physical therapy notes, so we know their assessments. And so really what the machine can end up doing with this framework is know that, okay, I have an esophagectomy patient, so I know their vital signs are stable, their nasogastric tube has been removed, their Foley has been removed, they're off of IV narcotics and their pain is well controlled, but I'm still waiting for them to be able to eat using their mouth, that physical therapy needs to see the patient, and that they need to have a barium swallow imaging study done. And so that's how the machine can predict which patients should be leaving or are clinically ready to leave. And so the output of the tool is a rank-ordered list of every post-operative surgical patient in the hospital with a score that's associated with their likelihood to be clinically ready to leave within 24 hours. And we rank order those patients. We also automatically display all of the barriers to discharge on the right-hand side that the machine detects and displays in order of what it thinks is importance to getting the patient out. And then we have a retrospective list. So in green are patients who were from yesterday's list who were expected to leave and actually successfully left. And it's these red patients who were clinically expected to leave but didn't leave. And this is where we do a lot of our learning about how we can improve our processes at MGH to get these patients out in a more timely fashion. And so just to finish up here, we did a 90-day pilot on 2 inpatient general surgical units. We worked with nursing leadership, physical therapy leadership, case managers, MDs, PAs, NPs to improve the model, make it better for their use, actually incorporate their feedback, but also learn why these patients weren't leaving that we predicted should leave. And we found that during the 90-day period, there were 95 patients who were clinically ready to leave but didn't leave because of non-clinical reasons. That summed up to about 128 bed days that were lost. That's just in a 3-month period on 2 inpatient floors. So the future of this project, one is fulfilling that goal of a real-time tool that's used by clinicians every day, but also is looking more broadly to what we would hope is Partners 2.0, which is a learning system within all the hospitals at Partners. So, for example, you can imagine that at Newton Wellesley, they may be best in class at efficiently taking care of total hip replacement patients. Brigham might be better at colectomy patients. North Shore may be more efficient at cystectomies. And so our model could be that we train the tool for each of these surgeries at those particular hospitals, and then we predict for patients at MGH. So we really open up where are the opportunities for us to improve our practice. And hopefully MGH is best in class at some of these other surgeries that they could then feed back to the other Partners hospitals to help them improve.
So just to summarize, and then we'll all come up and answer questions. So you could say, why anesthesia? Why are we interested in artificial intelligence? And I would say we are the masters of physiologic monitoring. In the OR, you saw that basically our presence is to monitor all physiological functions of patients. And I would argue that increasingly we're monitoring even more. We monitor the brain. Ultimately, I'd like to see organ-specific monitoring, as well as immunology, as Dusan said. So we have monitored, and we're going to extend our reach. We have projects that involve giving wearables to people who are at home so that we can improve our predictions for risk for going through procedures and see if we can modify those risks. We also are Kiana is actively monitoring patients after operations so that we can pick out patients who are doing poorly more quickly. And we've also found, if you will, group dynamics that lead to poor outcomes and have tried to improve those. We can help other groups monitor, and we're working with neuropsychologists, neurophysiologists to look at delirium and what can we do in terms of prediction and treat those, as well as immunotherapy, and look at a group of patients who are undergoing the most advanced therapies for cancers and try and improve their adverse outcomes. So with that, I would invite all the panelists up here so we can answer questions. Sure. Are there any questions?
Question. Please step up to the microphone. Just because they're recording and others can hear. Thanks, Matt.
Sure. So I have a question for Jim Phillip, who was talking about the quality of data for an AI input system.
It is on.
It is on.
And so I wanted what would be the sources that you would see as most important? And I offer the following three thoughts, three or four thoughts. Continuous non-invasive blood pressure, continuous cardiac output, non-invasive, all infusions mapped into the chart, and then better brain state monitoring, and any others you might think of.
I think that we are on the forefront of finding new things. We have no immunologic measures. Those will be crucial to what we're doing. We want to look at the patient's current state of stress versus strain of whole physiological systems all throughout the body. We don't understand oxygenation when we go beyond FiO2 that's high enough to have saturation be 100%, and we learn nothing about the patient's lung shunt, which we should be monitoring continuously. We want to look at the patient's compliance, but some of our monitors do that already for the respiratory system. In other dimensions, clearly brain state will be crucial. We have that. We've got measures. We're getting new ones as time goes on, and that is still continuing to evolve. Beyond that, I think I'll stop there for the moment. Thank you.
There's already been publication using 16-lead EEG, and actually you can go back and predict. Once you measure blood levels in a bunch of healthy volunteers and the depth of anesthesia, you can actually predict depth of anesthesia and reliably predict blood levels based on the EEG. So, and that's using just machine learning, just using the EEG and feeding it what was going on at the time. So there's already been some pretty good evidence that you can use really complex data. 16-lead EEG doesn't get much more complex than that to detect states.
That's interesting that the artificial intelligence engines looking at the variables themselves can sometimes do better than what we are currently doing with the measures that we are actually making. That is, when the artificial intelligence engine can predict the depth of anesthesia, and it does it as well or better, as Dr. Rathmell just pointed out, as our brain monitors themselves, it really says there's a lot to be learned. And it's an opening for researchers of all sorts to be looking at these things, collecting that data, and then all of us collectively will be able to do that much of a better job.
Good question. Well, I'll put one to everybody. So, oh, there you go.
Yeah, let me ask you a question. I work with GE, so we are in the business of making some of these devices. You know, if you look at a hospital today, there are multiple systems. You've got EHR, you've got devices on floors, you've got central stations, you've got spot check devices going all over the place, and they're sort of different systems in a hospital. If you were to fast forward 4 or 5 years, a question on what state of the world do you see? Do you see all this data as a part of the EMR? Or do you see sort of a dichotomy where EMRs are more for medical, legal, and documentation purposes, and some of these other devices which have, some of these have 250 hertz, pretty dense data, each bed putting out a gig of data every day. Those systems will be different, and you'll be doing some of the algorithms and visualization on a separate set of systems. What's your view if you fast forward a few years?
Sure, I'll take a first shot at that. So I think that where we are now is we're trying to think of when you need this high resolution data and all these other data sources, we don't want to burden the EHR with all that. We want to work outside of the EHR, create algorithms, software as a medical device, run those algorithms against that high resolution data set, and when something useful is detected in there, then feed that incrementally back out to either alerting a clinician or putting something significant back into the EHR to say this event happened. So I look at it as the black box recorder, the high resolution data, and then the AI running on that, and when we find stuff, then moving the information back out to the EHR.
Is that because of the evolution, the electronic medical record, we won't say the name, but has evolved? Could it have evolved in a different way, or is it just because we're so far down that pike with cumbersome, non-interactive, static electronic medical records that just collect data and put it in various bins?
I just don't think the EHR is equipped to hold all that, and a lot of this data might not ever be useful. I think you need a lot of data to look at, to create the patterns, to understand. And I don't think the EHR is equipped to sort of house that. I think, as we look at our institutions, we have all these, we're at capacity. We have all these patients, and there's a lot of information there. It can't really live in the EHR, and the EHR isn't really set up to hold all that data for that retrospective analysis either. There are limitations of the EHR where you have either 1 minute data resolution with the data going into the flow sheets, as well as some EHRs require a clinician validation of that data. So you're either going to put a lot of burden on clinicians to validate all that data, and if it's not validated, then once that patient's discharged, the data's gone. So there's some infrastructure challenges with leveraging the EHR. I think you can glean a lot from the EHR, and depending on the project, you can look at the EHR for certain things, like Keon in his example, looking at medications and some of the physiology. But if you really want to do that high resolution analysis, I think you need to have a separate high resolution biomedical data repository. But the real challenge is linking that data to the patient so you can put it in context with all the EHR information. So they can't really be silos. They have to sort of work together. So I look at it as an active monitoring high resolution data source, and then information back.
I would suggest, so that's great. My feeling, I would suggest perhaps a deeper problem is the question of the semantic weight of the data. So you have access to all this data, but the question is which is important. And in the EMR at the moment, it's very possible to push lots of data towards it, which you can then get as the clinician, but with no real structure to it as to which parts of it are most important for taking clinical care of the patient. And so the things you care about can become lost under a welter of other data. Whereas with paper records, when people had to handwrite them, it might not have been nearly so encyclical, but someone had to think about what was the most important information to pass on to their next colleague. And so it was structured in a much more hierarchical way in terms of what was semantically important. And that's kind of lacking, I think, from modern EHRs.
I will say as a clinician, though, we need all the data to be, just as Bill was saying, in one place. So now we monitor patients on ECMO, on LVADs, on transport ventilators, and these are really sick patients, and we're moving them all over, flying them into the hospital. We need to see the data in real time, and we need to make decisions on those patients. So we're looking for companies that can get all the data from various devices and synthesize them and allow us to look at them. So that's going to be a big deal. We don't want proprietary devices to keep us from synthesizing what's going on in the patient.
I think we also should realize that if any data goes into the patient's record, that data should be in the mind of the anesthesiologist while caring for the patient to make sure that it is acted upon. We never want alarms to appear in a record that the anesthesiologist didn't know of and act on. So hidden things of that sort we've seen occasionally in the past, that will make us liable because we didn't see what the monitor did see. So the monitor disclosing to us all of those things, I think, is crucial. We also have a certain set of variables that once upon a time the anesthesia monitoring standard was very simplistic in its time, but it was very profound in its time, defining exactly what should be recorded in every record. We understand that as we have evolved, that should evolve with it and probably should go along with the new monitors, rather the new variables that we are monitoring, something that says that we should be recording them and thinking about them, just so that we all know where to begin and where not to end on that monitoring.
Okay, thanks. One question I want to put on the table, and if we get some time later on, we should talk about it, is how will the regulatory framework evolve around it? Because as we develop all these algorithms and the like, it still takes time to get here. So one product that is launched in Europe a long time ago called end-tidal control is doing phenomenally well. It reduces the cost and it improves the safety, but we still haven't been successful putting it to the use. So at some point, if we get some time, we should talk about how the regulatory framework will evolve to take into account, once you have full liquidity of the data, you will develop a lot of very interesting algorithms, but getting them through the regulatory cycle might take a lot longer. So something to think about.
Matt, could you comment on that? You probably have the most experience of all of us in regulatory frameworks.
So the question was raised really around the topic of, in a way, software as a medical device, right? Where a team, usually in a provider organization, develops some sort of an algorithm that would seem to require FDA regulation because it processes data in a certain way and presents it to a caregiver who is likely to write an order make a prescription or make a diagnosis based on that data, that would fall within the regulatory framework, presumably. The only experience that I have about how one might make a system or a product that doesn't collide with a regulatory framework was the patents that we wrote in 1992 for a so-called smart drug infusion pump. The goal of that product was simply to put information about drugs, the way we give them in a particular hospital, in front of the caregiver as they're programming a device, both to pick up any errors and prevent them before they occur, but also just as a knowledge and best practices dissemination tool. The problem in making the invention was that most of the uses of drugs in hospitals are off-label, i.e. No manufacturer can never put that data in the medical device because it's an evolved form of medical practice that's really governed by the particular hospital you work for, their board of trustees, and the community that enables the hospital to be there. So what we did was simply interpose the responsibility of the information or the rule set to be owned and validated by the hospital before being loaded into the medical device. So I don't see why all new products that are software as a medical device require the full FDA 510K approval if there's a step in the development and the use of the device that basically allocates the responsibility for the medical judgment that's encoded in the algorithm. The responsibility is on the hospital that employs the caregivers. I don't know if that's comprehensible or not, but it certainly, worked as a strategy. So basically, rather than trying to get 510K approval for every software as a medical device that recommends a clinical practice, which would seem unworkable, and also it can't be iterated. Once it's approved by the FDA, you can't change it. So the alternate approach is to say, design your software as a medical device so there is a step in the utilization of it that documents a provider approval of particularly all of those elements, which are most of them, that are actually off-label.
To take that to complex physiologic data, where they may extract using machine learning some sort of an alert, there has to be a clinician in between. And that's what we've seen with like the Alert Watch program, where it gives you an alert. So it uses an algorithm that says this might be a dangerous condition evolving, and alerts the clinician, and it's up to the clinician to do what they will with that
So just to take it a
information.
little further, and I won't present any other questions, but Jim's pointed out that if the system is designed so there's a human in the loop with respect to the output of the algorithm that says, patient X with a mood disorder based on his iPhone data may be heading into a decline and you need that patient to have care. That step of involving a human reviewer of the data as a step would be sufficient to avoid the regulatory tangle. And while I think that's a key element, I don't believe that's sufficient because the thing that's the device, the system, the software as a medical device, is the algorithm that takes all sorts of diverse data from a patient, whether it's physiological data or behavior data, and processes it in a certain way and spits out an output. The patient is suicidal, do something. And just because you put a clinician on the recipient end doesn't seem to me to resolve the regulatory problem. So the notion would be, let's suppose there were 4 academically reasonably well-established algorithms for predicting suicide in patients with mood disorder, based on their use of the consumer devices.
And the concept would be that the provider organization or the clinician is choosing which of a plurality of algorithms, each slightly different, are going to spit out that answer that leads to the clinical outcome. And I think that's my sort of drug library analogy, right? any hospital could make up a cocktail of drug that was terribly dangerous and embed it and upload it into an infusion pump, and bad things could happen. The manufacturer of the pump is protected from the liability because that's allocated to the organization that created the rule set. So that's my pitch, is that the rules, there has to be some choice explicitly made by the provider organization to customize the rule sets for, and I think this, I haven't looked into AlertWatch in great depth, but I wonder if that's a problem you're not going to, that AlertWatch will bump into. Each hospital's going to want to customize, what it is that triggers a call to a clinician.
All right, let's see if there's other questions.
Yep.
Anybody else?
I've got a continuation on what Ajay Park from GE asked, and that Sims from Mass General. Thank you. That's been great. The end title control from the FDA, their position is when you test it, you've got to test it that anesthesiologists don't make patients' blood pressure fall or rise, because the package insert for the drugs that it is delivering say that those are the complications of those drugs. So the FDA is in a very awkward position and recognizes that it's in that awkward position. They're not questioning whether end title control is going to work as end title control. They're questioning whether we as clinicians will be hurt by it or our patients will be hurt by it. If it fails those initial tests that are going on now, in fact, for the first time in the past 3 years, probably the company will have to go back and say, we will have to teach clinicians that not to set their end title control where their target was before, because for 50 years they've never been getting to that target. For the first time, we're giving them a product that really does what they think that they were doing. So it's a very, very sticky slope on that, but a very interesting, perplexing place for the FDA team.
So why don't we get everybody to weigh in? If you're an investor or you're going to invest your own money here, and where do you think we're going to see AI really make the biggest changes and the earliest changes in our field? We've talked about a lot of things that are kind of new and emerging. Where do you think it's going to be? Yeah?
So I think one challenge is where not to focus, first of all. So I think anesthesia, to some degree, especially in the OR, is a field of very, very rare complications. When it goes bad, it can be very bad. But I think what we don't want to do is invest all our dollars in making a complication go from 0.001% to 0.0001% using AI. And there's a little bit of a, there are some problems in anesthesia that are very attractive, but they're extremely rare problems, and I think we probably shouldn't go there. I think places that are ripe for it, for example, in the OR, have a lot to do with blood pressure management, for example. So there's actually already pretty good data and even systematic reviews looking at some of these closed-loop anesthesia systems that have been able to reduce the fluctuation in blood pressures that are very common and pretty severe in very medically complex patients, for example, getting vascular surgery. The problem, I think, from an investor standpoint is that we're not sure how those blood pressure swings necessarily impact the outcome of the patient after the operation. Does it increase their length of stay? Does it increase their rate of post-op MI? Those are questions I think need to be resolved, because anywhere where the dollar should be invested, there should be a very clear ROI, either for the patient or the provider or the health system, or hopefully all three. But the ROI has to be very clear. So at least that's my thought about initially where we might focus.
I think that a lot of what is done in particular areas within our field is looking at images and figuring out what to do with what we see. We recognize from the radiologic area that they've done an incredible job of recognizing that AI there, they will allow themselves to replace themselves. And it's the radiology departments that are in fact developing these AI tools to recognize the patterns and detect the tumors and things that we saw all sorts of presentations on this morning. We have things like looking at the cardiac echo that can probably be analyzed. We have things as we're placing needles very carefully in wonderful places to treat pain properly, to see if those things can be improved with, again, artificial intelligence, looking at the image, understanding where things are, looking at it in 3 dimensions, and identifying where that 4th dimension of time and where that needle should go in the future.
So we as anesthesiologists and intensivists take care of patients that often have suboptimal outcomes in intensive care. Mortality for sepsis, septic shock, ARDS trauma is still high. And really the next frontier in critical care is to identify subsets of these patients, so-called endotypes or subsets of patients with ARDS, sepsis, that behave similarly, that do respond favorably to certain therapy. Really, the example that we can look at is oncology, where many cancers are really phenotypically defined into great detail, and as a result, you can see utilization of immunotherapies which precisely target certain mechanisms. This is something we have to do in sepsis, ARDS, trauma, and currently we do have technologies that are already adopted in oncology that we could use in the intensive care environment, such as single-cell RNA sequencing, mass cytometry. Really what is unique for diseases that we treat, they develop very quickly, rapidly, which is in contrast to many patients in oncology where the disease lasts for several years. Therefore, we have to adopt technology or invest into methods that are able to give us precise information very quickly, within first minutes, hours of the disease.
I would say that I think it can touch on all aspects of anesthesia, from the preoperative side to sort of using the data to identify which patients are at risk for surgery, through the clinical care of the operating room, looking at all the data that we can gather, predicting which is the right anesthetic for that patient, all that information that could say this patient is on track to go to sleep and wake up on track and go to the recovery room, and when they're deviating off the course. I think it can help administratively when we have to look at the staffing that we have and how to fill the staffing to fill all those procedures across the hospital. We can use AI to help fill out the schedule more efficiently, to match the staff to the schedule and match the schedule to the staff that we have available. I think post-operatively through remote monitoring, just prioritization and triaging to help the PACU attendings figure out which patients are the next one to be discharged from the PACU through the ICU care and the hospital capacity, as Keon said. So I really do think the platforms are evolving, they're coming together, and we're able to do demonstration projects, and now we just need to take it over the finish line and optimize those projects.
If I had to pick one thing, then I would certainly use the rule that my colleague down there proposed, which is that a limited optimization to something you do commonly is ultimately better for you than an optimization of something that's rare. That makes a lot of sense. So if you think about where the money and the time and the effort flows through the OR, a lot of the optimization seems, a lot of the early optimization seems to me to be in terms of decision support for scheduling and staffing, which is of the nature of the app that I showed you in the beginning of the talk, which was specifically designed for groups that go to multiple geographic locations. Your group may not do that if that's in the nature of your practice. But that's where the money is. As I said, anesthesiologists are expensive, but worth it, I would say. I mean, for those of you who are businessmen, I mean, you think what's an inelastic commodity, and you probably think of oil. I would suggest that it's the relief of excruciating pain. You would do anything for that. So to have something that helps improve your staffing and your flow, and therefore the number of patients you can treat, is both financially good for the hospital, for the anesthesia department, and also it's a societal good because it allows you to treat more patients. And that sort of decision support, scheduling assistance is at the easier end of AI problems, where you still have a human in the loop, but you're relying on the software to gather data that they couldn't easily access, like in the app, the location of the providers. and then provide them with that data in such a way that they can make more informed and better decisions. So I think that's where I'd look first.
No.
So I'm an intensivist, and I see it as a frontier where we push the limits of medicine. The problem is we also push the dollar amounts you can spend on human beings and not always for a great outcome. And I would say that's where artificial intelligence could help us. I mean, we can keep people alive, but keeping you alive in the hospital is not really our goal. Our goal should be to keep you alive so that you can go home and thrive. And we need that data. And it's really expensive to keep people on ECMO and LVADs and RVADs, and we need to look at those outcomes. Same with immunotherapy. Great for 15% of the patients with tumors, but we need to know which patients really achieve that goal, because those therapies cost about $500,000 each. So I would go for the more expensive therapies. The OR is expensive, but nothing like critical care.
Yeah, imagine an AI algorithm that predicts futility, and you're the recipient of that information.
But
You know,
that is what we
can do it.
ultimately have to do.
The futility of care. Other questions? Don't be shy.
Just a comment, listening, and I will speak loud, to the comments that basically said that money in AI is going to be in time and flow management. And the example that comes to mind has to do with aviation. A lot of stuff that's promoted.
If you're going to go on, again, they're going to yell at me if you don't get up to the microphone.
So if you look in the aviation domain, a lot of things that are presented to the public as safety mandates are actually about flow control and massive scaling of capacity. And so each of the little stories you told, finding the staff, automating the schedule, figuring out which patients are ready for discharge, studying the red patients who should have been ready for discharge but didn't, that feels tremendously powerful from a sort of Partners 2.0 economic and scaling. The example that I would cite is flow control for airlines coming into major airports. You know, we are all experts on aviation because we go on commercial airliners all the time. What we don't realize is the capacity increases that have occurred in the last 20 years. The numbers of increased millions of passenger seat miles per year, the reduction in accidents, et cetera, et cetera. And the point I wanted to make is that, for example, with FedEx, which has to get, I don't know, 200 or 300 cargo jets in and out of, into Memphis, and then out of Memphis within a 4-hour space, they now use precise GPS targeting to be able to predict 3 or 4 hours ahead of time the actual wheels to the ground to plus or minus 5 seconds. And the way in which they actually get the flow control to work is that they can, if you have a lineup of 15 aircraft coming from the West Coast, and one of them spaced a little too closely to the one in front of it, they can just take over the heading bug, as it were, and do a small S-turn without touching the throttles, without changing the speed, to just add a tiny increment of the distance that the aircraft has to fly, so the spacing will recover itself. And in fact, Steve Schaefer, when he was here at MGH giving grand rounds in anesthesia, basically said, if you want to think about how AI is going to impact healthcare, you know, just watch how good Google Maps is at predicting how many minutes it's going to take you to drive from point A to point B, because it takes into account all the traffic accidents and the backups and the weather and so on and so forth. So that's my story, and I'm sticking to it.
Do you think we'll be able to do that intraoperatively? So the problem that we have is the great variability within a given type of surgery. How well do you think we're going to be able to do at predicting like intraoperative case, like all the things we need to do to get good flow control, if you will, through an operating room.
I think to some degree it depends on how big your training set is for your AI tool. So I think it was lucky that I was ready to do this project when I was, because at that point we had about 2 years of EPIC data under our belt. So we could train our tool on about 20,000 surgical patients. So you need, especially with a lot of variability, you need a lot of patients in order for the tool to get an understanding of, okay, these are the minor patterns that need to make me deviate towards, this, particular output versus that. So I think that's where, for a lot of reasons, actually, EPIC is, we're not supposed to mention the name, our electronic medical record has been extremely helpful. Is A, it's centralized all the data in one place. B, it's much more structured and therefore queryable. C, at least at Partners, we're at a point now, several years down the road, where we probably have large enough training sets for a lot of the clinical questions we want to ask. And another point to mention is that data can be queried on a real-time basis now, or a near real-time basis, using web services that the EMR makes available. So for all those reasons, I think the main answer to your question is we need really big training sets, I think. And 20,000 might not be enough for some questions. It may be more than enough for others.
So what do you do with a consistently inconsistent practitioner? How does AI handle that person?
Well, if it's seeing the practitioner, it should be able to assign that variability to the practitioner. So as long as it knows, who, and actually our EMR systems are very good at knowing who's the responding clinician, who's the primary service responsible, especially in the OR, who's the attending, who's the resident, who's the CRNA, et cetera. So it should be able to attribute.
So what do you do with that? Now you have the consistently inconsistent that does the same procedure lasting from 60 minutes to 4 hours, and you're trying to set up their surgical day in an efficient way. What do you do with that?
Probably process improvement around that particular
Work with the practitioner.
anesthesiologist.
No, not necessarily. I'm talking about surgical length of surgical cases, which is really what drives most of what we do.
Well, that's what I think. What we've found is that there are certain real-time gains you can get. These can be tools that can be used in real time to improve practice. But there's also a benefit to looking at the data in aggregate and being able to show whatever stakeholder is relevant to address that problem, whether it's the OR schedulers, whether it's the surgeon themselves or the anesthesiologist themselves, or whatever stakeholder, being able to show them the data and quantifiable over X amount of time is very helpful. So I guess that is a partial answer.
Yeah, I think with enough data, you can pinpoint where they become inconsistent and work on that, like Keon said, with a process improvement project.
Chris, you want to stochastic processes like this, you've got this incredible variance, and across different clinicians, if you still maintain that, the best you can do is have more operating rooms, and on the average, have them all end at the right time, but along the way, have no control in the middle of it until you can get control of the variance of each of the individual, in that case, items, but these items in this case are surgeons with surgical time. And I think we all need to look at how long it takes us to do things and our colleagues to do things and see what we can do to bring that into some better alignment.
I'm not sure I want to prove it fully on a whiteboard right now, but my mathematical hunch is that you allow surgeons who are more reliable to schedule their cases earlier in the day, such that unreliable surgeons get pushed out later and don't delay randomly many other cases. So their punishment for being inconsistent is that they don't get to start until later, and then mostly they delay themselves or can't complete the cases they wanted to do in time. So you get, this is all network analysis and minimum cost, maximum flow. That's the branch of mathematics we're talking about. I suspect it would solve out that way.
Other questions? Please come.
Yeah, hi. Just now, you guys talk about a big picture in anesthesia. I have a very small question. Yeah, just recently, I'm involved in a small project about ultrasound-guided original anesthesia. So, do you guys give some opinion or suggestion about that? If we use artificial intelligence can identify the ultrasound nerves or every ultrasound images.
So your question's about ultrasound-guided regional anesthesia.
Yeah.
And where would artificial intelligence be helpful? I mean, I think, so where people struggle, so first of all, in the training, accelerating the training by pointing out structures. So giving it data sets that say this structure represents, because there's great variability in what a nerve looks like.
Yeah.
Sometimes it's relatively echo-dense, and sometimes it's less echo-dense, depending on the amount of fascia and areolar tissue within it, or where along the nerve you're imaging. And that confuses practitioners when they're quite early in their training. So having that sort of identifying structures with higher or lower probability, even if it gave you the probability that this is vascular, soft tissue, or nerve on the screen, would be a big leg up in the training. And we have experts that are way up here that could do that with big data sets, just tell you what it looks like.
I actually worked on this a few years ago. So what you really need is a big library of labeled images, and then you need an algorithm that can take the image that you have on the screen and try to find the things that are invariant in it to map it to invariance in your marked set, so that then you can describe on the screen what the targets are. So if you're trying to do some form of supraclavicular block, it can map or distort the image in its training set to help you identify which structures you actually have. Because there's really two challenges for the trainee. There's identifying the structures, and then there's the kinesthetic skills of manipulating the needle to get it to the target. So if you can take at least one of those things out and tell them what they're supposed to aim at, that, I think, flattens the learning curve.
So that's the use of ultrasound to place peripheral nerve blocks, local anesthetics on peripheral nerves for major surgeries. Any other questions? It's a shy group, or? All right, any of you want to pose a question? No. All right. Well, so I think the other big area that I'd like for people to comment on is looking at, so the idea that we can take these we often have large data sets on patients' preoperative state, if you will, right, including their medications, but there's a lot more that we collect. How would we go about solving that problem? Would artificial intelligence then help us to say, to pinpoint, without us having to say cardiac risk is or pulmonary risk is, could artificial intelligence help point out the information based on historical algorithms, or even better yet, if you fed it enough data about preoperative state and final outcome for each given surgery, could you predict patients who are not going to do well and perhaps have different discussions with them? So you're at, and how would you have that conversation if you really didn't know what the algorithm was pinpointing as the problem, right? Because we may not know that. If we feed it big data sets, we just may know that we've got a high-risk patient for reasons that classically aren't apparent to us. It could be interaction of two different things that we never recognized before. Yeah, what do you think?
I think it goes back to what Jeanine said before, which is that I think the big missing piece of data in our preoperative assessments is really, and probably the most valuable kernel of information, is functional status. I mean, it's a hard to define thing, but we all know it's extremely important in predicting how you're going to do, not just in the OR, but in the ICU and everywhere else. So I think we need better than just the patient can do 4 METs or more, the patient can go up 2 flights of stairs without getting short of breath or having chest pain. That is just obviously far too blunt. I think having, for example, so we need more data. How do we get that? I think attaching, non-invasive continuous physiologic monitors to a patient that can measure, and we're starting to look at this, temperature, activity level, heart rate variability, cardiac output, tidal volume. I mean, these wearables are actually very decent, and many of them are FDA approved to look at these various parameters. So it's pretty easy, see someone when they go to their preoperative surgical visit, they get prescribed a little patch. The patch goes on them for 3 days, and we would get back in real time and in aggregate a lot of information for us that can help us decide, well, they seem to only go up 3 flights of stairs every week, even though they report going up 4 flights of stairs every day. And by the way, their heart rate goes through the roof and their oxygen saturations goes to 80%. Now that would be very, very useful information. I think that would help our preoperative assessment quite a bit.
And we also don't have any idea what their conditions are during their sleep. We worry about things like hypotension during anesthesia and have no idea what the natural processes have done for the same patient the night before. And I think that would be along, again, exactly the same data lines to make sure that they don't take the patch off when they go to sleep.
Maybe just to add what just Kian said, early mobility is important also in the ICU and really predicts how patients will do down the road. So monitoring mobility early on during critical illness and during recovery with patches, for example, with sensors that will register the 3D movement might also be important.
Yeah, I'd agree. I think shifting from the subjective patient questionnaires and the preoperative process to more objective data through these technologies and some of the presentations we saw this morning with really simple non-invasive devices can really help get that objective data so that the very first data point isn't in the pre-op holding area.
I'm going to go contrarian on this one. I think the opposite of all my colleagues. I think the most important thing is the question of the hunch. So if you have a patient who seems like they're going to do poorly or do well, this is a decision that you arrive at subconsciously when you're experienced provider. You see them, like I showed you the pictures of patients who are likely to be easy or difficult to intubate. To an anesthesiologist, you see that, and it's subconscious that you make that decision. So more the interesting question is, how do you actually surface what the decision-making process is behind that? You can't ask me because I don't know it consciously. But at least for the difficult intubation problem, we were able to do that by training a machine learning algorithm to pull out the features that it thought matched best with patients who went on to be easy or difficult to intubate. And then we took those parameters in the second paper and we created a range of artificial heads, or we looked at how those things correlated to the decisions that the anesthesiologist actually made. And it turned out to match. Those features that we saw were actually seeming to form part of the basis of the anesthesiologist's decision-making, even though they didn't know that. So to me, the whole benefit of AI and machine learning is to answer that question of what is a hunch? Something you've learned but you don't know how you learned it. What is the lesson? How can you say what the lesson is until it's learned? If you can pull that information out, I think that actually is incredibly valuable. And I talked about that with one of the cardiac surgeons in an outside hospital where he said, I meet these patients and some of them I just know they're not going to make it. Is there some way that we could try to find out what that feeling in the hairs on the back of my head, what causes that? And that, I think, is the question I want to answer. That's certainly the question I think where machine learning can come in and help us to tease out our own thoughts.
It's what we can learn from the artificial intelligence to have it become human intelligence.
Just have about 2 minutes left if you want to ask. We'll quickly answer one more question.
Okay, I've heard a lot how to use the concrete objective data to feed into and making a big artificial intelligence machine. I'm a chronic pain physician where there is a lot of data which is subjective, not really objective. Where does artificial intelligence stand and what can we do with artificial intelligence in that field?
Yeah, it's a very good question. Could we predict early in the course of chronic pain, what are the predictors of people who go on to chronic long-term disability? And then can we alter them? That's where we may, but it's going to take many, many years to do that. I think the simplest, the earlier answers are, what are we doing with therapies and what actually happens? And can we, if we do a therapy, like chronic opioid therapy, does it help anybody? Well, we can use large data sets to sort of drive that. Instead of empirically coming up with what optimal doses are and maximal doses of opioids, why don't we figure out who's going to be at risk very early on and then put all of our resources there? But we're so rudimentary in that. We don't even have just data sets that tell us the other things that are happening to our patients.
Jim, might that mean that we need to be looking at our patients more intensively post-operatively and their entire post-operative course? If we've got the tight data set intraoperatively, we've collected the data and didn't know what to do with it, now all of a sudden we have something that possibly we can do with that data.
Well, absolutely. I mean, that's what all of our research in anesthesia isn't limited to the intraoperative or maybe as far as the post-anesthesia care unit. Now we're much more interested in long-term outcomes. Well, I want to thank everybody for coming, and Off we go. Thank you. Thanks very much.